Good morning, I'm Jonathan Montgomery. I'm Chair of the Health Research Authority, but also Professor of Healthcare Law here at University College London. And I'm sorry I can't be with you this morning, but I hope I can introduce a few issues that you can discuss and I can get some feedback on how we can move things forward together. So the Health Research Authority is here to protect participants and indeed potential participants, but also the general public by encouraging research to be carried out that is safe and ethical. But we have a function of promoting the interests of everybody and having a good evidence base for research. So our aim is not to stop research, but to make sure that the research we need to get a good evidence base for care carries out. And our key aim then is how can we make sure that that happens. We look for quick wins in the regulatory process. So on the first day when we were established, we integrated the Gene Therapy Advisory Committee into the normal REC system and immediately shortened the timelines that had been created by the separate committee. We picked off some myths that held things up, such as the idea that everybody involved in a research project should undergo GCP training and work with colleagues at the MRHA to issue a statement that that really wasn't necessary, not that everybody believes this even now. We aim to give guidance where we can about how things can be done more proportionately. So we took advantage of a part of the developing clinical trials regulation to issue early guidance on how we could get easier and more straightforward consents given in pragmatic and cluster trials. And we try to pick off issues that have emerged about cooperating across the UK, because the Health Research Authority is only responsible for these processes in England. And we work with our colleagues to try and shift the focus of governance away from a governance framework to worry about whether research is carried out well, into the new policy framework issued last year to be a framework for carrying out health and social care research, which you can read at the URL on the slide if you haven't seen it already. But the fundamental idea is to move away from thinking that research is potentially risky and difficult and therefore we should be cautious about doing it, into thinking that it's an integral part of giving high quality care. The big task we had was to try and address the complexities and delays that research and development approvals had created in the NHS. And what we've essentially done is try to work out what the NHS needs to do in local organisations and what can be done on its behalf through the Health Research Authority. So on the left-hand side of this slide is a series of things that the NHS used to feel it needed to do, many of which were being done more than once in lots of different parts of the country. So all the areas of legal compliance should in principle be able to do once per study and everybody else could take advantage of that check. If you like, the principle behind this is let's do things once and trust each other to have done them well. And the job of the HRA, through the initiative known as HRA Approval, has been to move as much as possible from that left-hand box into the work that it does as a service to the NHS of assuring compliance. So the new system of HRA approval that's in place has moved a lot of those activities into the remit of the Health Research Authority. So we will be ensuring that there are appropriate insurance and indemnity cover. We will be dealing with issues about legal compliance and we'll provide a report to the local organisations that indicates why they can regard it as appropriate to participate in trials. And what we're aiming to do is to get the local NHS research and development officers focused on whether they are a good site to do the research and what they need to do to get things up and running, and not to be focusing on asking questions that have already been answered elsewhere. Now, it sounds like a good idea. We have reasonable evidence now that it is, on average, working reasonably well. So this system has managed to reduce already the median times for approvals from the time of REC application to recruitment of the first patient in the third quarter of 2015 to 16, before this system was in place, was 231 days. That was a lot lower already than some of the horrible stories exposed by the Academy of Medical Science report in 2011. We've got that down to 142 days of an application coming into us to the first patient being recruited. And in HRA work now, we now have the bulk of the research and development work working through our processes. So that feels like good progress, but we know that it isn't uniform, and we know that not everybody trusts what the HRA does yet, and so we're worried about having diverted a lot of effort into additional steps that we can't see, which happen before applications are put into us. And I know about that anecdotally, but until I get some details of chapter and verse, it's very hard for us to follow up and to understand it better. So our sense is we've got a system that can work, but it's not yet a system that is working, and that's where I hope to get some useful intelligence from you. We have internally still got a lot to do, and we have a service improvement plan which is aimed to improve your experience, make it as seamless as possible, as predictable as possible, and to cut out unnecessary waste in the system. So, for example, we've discovered that rather than having a single point at which we can make sure that everything is in place, we keep coming back to you and asking you about things. So we've certainly identified that we ought to be able to shift from 13 times that we come back and communicate with researchers into 5 steps in that, and no doubt better still in the future. But it remains the case that it's clearly too difficult to make the system operate. This slide shows how many of the applications that come in for consideration to the HRA are not actually complete. So even in the commercial sector, where you think they would be able to invest money in getting this right, back in April 2017, 38% of studies were missing key documents and therefore couldn't be properly evaluated. We have to be able to make it easier to do that, and we need to know why it's hard at the moment. We know part of that is IT, that the IRIS system is clunky, and we're working on re-providing it. But I'm sure there are many other things that you can explain about why it's difficult to use the system. The big challenge, though, is R&D and NHS provider culture. So we're trying to think of ways in which we can develop a can-do culture in R&D. Let's get on and do this because it's a good thing to do, and not a culture of that feels very risky and it's the least risky option is to do nothing, which we feel is still part of the problem. And what we need to do on that is to try to normalise research in the activities of the NHS. So we're working with NIHR and the Care Quality Commission about integrating hospitability to research into their sense of well-led organisations. So we're working on drawing up a metric that the Care Quality Commission would use in its inspections, which can then lead to work to help boards understand what they need to do to improve the research culture. Now, it will take a bit of time, but I think that's our way in which we make sure that the R&D departments see their job as aligned with encouraging research, because that's what their boards expect of them and their chief executive is expecting of them. What I'd really welcome in terms of products of this discussion and your meeting is a better understanding of where things are difficult. Partly, what is it that causes the hold-ups? If you can identify particular studies that have not gone through smoothly and give us their RS numbers, we can understand what we have done on that. And we can try and get to the bottom of how things can be improved. And we'd be really interested in some particular examples to work with you. There's also a geographical question. Now, are there places in the country that do things really well and places in the country that cause you enormous frustration? Because then we can go and explore with them what it is that makes things so difficult and try and understand what we might be able to do to shift that. It would be great to have from you some easy wins that you see to say, if only you just did this, our life would be so much easier, and we can feed those into our internal service improvement programme. And equally, it would be good to have a shopping list of examples of regulatory requirements that you don't think protect anybody and do any good and merely waste resources, because we're kicking off an assessment of what our programme of work on proportionate regulation should look like. And we have a discussion at our board meeting next week about how we can move from the exploratory phases of that into designing some sort of programme. So I'm sorry I can't be with you, but I hope that gives you a flavour of the sorts of things we're trying to do and an invitation to contribute to improving the system further. Thank you very much.